the objectives of the talk will be and reveal the current treatment strategy and inborn error metabolism, and also introduce some new advanced treatment and in the disease. You discuss some challenges and obstacles for various treatment approach. So you guys already got the pre-testing question. I'm not gonna go over this, but we will get back at the end to test the quality of my talk. Okay. So a couple of years ago, Dr. Gambalo and I wrote a review article about a current strategy of treatment in inborn error metabolism. It was interesting, and when you look back now and read the article, and some of the contents are already outdated. So you can see how fast this moves forward. And then I hope in today's talk I can cover some of the new advances in the treatment field. So no matter how advanced the treatment approaches are, they're all based on the basic principle of metabolic evolution. So inborn errors metabolism is a large group of inherited disorder and characterized by the defect of either enzyme or the cofactor, and so which make this in the metabolic pathway was disrupted. And so with this defect, and you will see the precursor and substrate will build up. And when you build up too much, it will be used the alternative pathway to produce the byproduct C. And at the meantime, your product will be decreased. So all the pathogenesis of the disease phenotype was coming from either the toxic effect of this accumulated in the substrate or the byproduct. Or you have a decrease in the product because those products are essential for the body work or function, so the effect of the insufficient product B. Eventually, the goal for a metabolism is to provide energy. So some of those are coming from insufficient energy supply. So this figure and actually demonstrate as a bird's eye view and for diverse and therapeutic approach in treatment. So as we mentioned, the basic principle, you have accumulated substrate. And so the treatment clearly, and we're gonna focus how to reduce the substrate. And there's three approaches, and either by dietary restriction, or you build up too much bile product, have to take away about this toxin, or and you just decrease the synthetase for the substrate. So that's all focus on the substrate. And so when you have a defect and you don't have sufficient product, and you have to supply the product. And the central defect was this enzyme or cofactor. So multiple ways has been developed to focus on this enzyme and replace this missing enzyme or cofactor. This include enzyme replacement, organ or cell transplantation, chaperone therapy, and cofactor supplement. So all is a focus on the central defect. We know enzyme cofactor, they are protein. So where they come from? And your body has a gene and to guide the process, make this enzyme. So anything we supplement this gene, we give a good gene, they can make a good product. And so that's an replace the enzyme. So I think this was kind of an overall view on how this and the treatment develop, what they based on. So we will touch on each point. So dietary management has been the mainstay of inborn error metabolism, right? And so this was a start very early on. We used the diet management in PKU, and we have a formula. And so this was mainly remove the offending amino acid. So offending and the substrate. PKU, you can metabolize phenylalanine. I have to remove and reduce those intake. And MMA, PA, and that's organic aciduria, and you can't metabolize a certain amino acid, we have to make a special formula. And then galactosemia, you can't metabolize galactose, so your diet has to be restrict this galactose intake, which was contained in the lactose. So, and also, we give a product bypass the defect. So for example, in the long-chain fatty acid disorder, and they can't use the long-chain pathway metabolize, but you can use media chain or use supplementation to bypass the defect. So I think in clinic or in practice, we always encounter some misunderstanding about the principle for treatment from patients or family. And so they think, okay, you give me formula, this is a treatment, but you have to decrease the offending amino acid. You have to decrease the protein intake in certain condition, like the PKU. If you don't use the low protein diet, no matter how much formula we give to you, it doesn't work. And for fatty acid disorder, if you don't decrease your fat intake, how much MCT oil supplement is not treat the disease. So this is something in practically, and we have to educate the patients. I feel if they have a better understanding, have a better compliance and a better outcome. That's when you do counseling, this is something very important, and tell them why, and they understand that they follow your instructions. So although diet has been very successful in treating many of the metabolic conditions, however, there definitely we're still facing a lot of challenges. And then, for example, the palatability, and so the patients just don't like it. The taste was not great, and so that limited the compliance, and also required a lot of effort from the family and the diet schedule. And for example, those glycogen storage disorder, you have to feed them very frequently, and so every 3 hours, and so that's a lot of effort and placed for the family, for the patients. Potentially, and if they don't have a metabolic trained dietitian and to supervise them, sometimes they may leading to nutritional deficiency because they're not eating the balanced diet. So all this challenging still is an unmet needs, and we need some new development treatment, right? So this was not only for new modality, but even for the diet itself. And so the newer therapy, newer dietary and strategy was it was discovered. So everybody know the large neutral amino acid has been used in treating PKU patients. The mechanism is this neutral amino acid competitively inhibited the phenylalanine enter into the brain-blood barrier, and so they share the same transporter. So if you give other one and a higher amount, so they will compete with the phenylalanine and enter the brain. We know the high phenylalanine in the brain was caused the developmental delay and the neurological deficit. If we give under the computer and higher dose, then we will suppress the Phe enter the brain. So that's decrease the clinical and effect. So the same thing, however, and this large neutral amino acid has a lot of shortcome. And for example, the taste was not good. Amino acid by itself is not good and the taste. If you combine so many, and it's a horrible taste. Second, and long term, what's the safety and efficacy is not clear, and we can't do lumbar puncture on patients frequently. That's not practical. So that's why this treatment is not widely used, even as a clever discovery, but due to the practically and it's not clear, and so it's only used adult, and which they couldn't control their Phe level by traditional treatment or adjunctive treatment at this moment. So using the same concept and then this diet.
Excuse me, Teresa, this is CDPH. I'm Deepika Mathur from Newborn Screening. I'm sorry, there's a few of us who are having a lot of difficulty hearing you at all. It's breaking up quite badly, and so I'm just wondering if you could do anything, perhaps maybe move your microphone or maybe increase the, we've got the volume, both of us from two different sites have our volumes all the way up. And we can't even make out what you're saying. Is there anything that can be done on your end?
Thank you for bringing that to our attention. They are taking a 1-second break to look into it for the other people who are online. Please hold on, we'll check and get back. Dr. Lee will get back.
Okay, and just to let you know, I'm actually able to hear you much better than her.
Okay, all right. She has to just speak loud like me now. She's smiling. So,
Oh, really?
So
Okay.
a microphone.
Oh, we don't have a microphone and PA set up in the room today, so sorry.
Oh,
Okay, I'll try. So yeah, so this not just used in the traditional Inborn era. Yeah, can you hear me? So this.
Yes, actually, this is better. Thank you.
Yeah, where is the
camera. Yeah. So if you get closer, you can get closer.
There. Yeah. So this is the same concept and the treatment, and not only used in traditional metabolic condition, it's also extended to other non-traditional metabolic conditions, such as this paradoxin-dependent epilepsy we call PDE, and which was a disorder.
Speaker's actually right here, so if you want to stand a little further back here, closer to that panel there, where the green light is.
Okay. So maybe this is better.
Yes, much better.
So this was also under use. This disease is
Actually, sorry, but I think when you move the microphone or when you move around, we lose the sound.
okay.
So I heard you okay well. Sorry.
Okay. So this also under use. This disease was mainly a seizure disorder, but it's also under the defect was in the metabolites of lysine, tryptophan. So the defect is a marker gene is called an antiquintin, and so the lysine and the last step of the lysine metabolites. When you have an enzyme defect or anything and the step was not going through, and your precursor substrate going up, and that AASA converted to the P6C, another metabolite. That metabolite was binding the active B6. So basically you deplete in your B6 level. And B6 is a lot of enzymes cofactor. So that's why they can cause the seizure. And so one of the main treatment was a supplement B6. So that makes sense, right? And you're missing something, and it's important and supply and where this come from, where this AASA and this and P6C comes from, and they come from the lysine metabolites. So if we can decrease the lysine, that subsequently we can decrease the effect, right? And so lysine, arginine use the same transporter and in the blood-brain barrier. And so same concept as this large neutral amino acid. So that's when you decrease the lysine intake, you increase the arginine intake, to make your content of lysine in the brain is decreased. So subsequently, and you decrease the toxic metabolites. So that's when the triple therapy comes through. So low lysine, high arginine, plus the vitamin B6. We have a couple successful story here. Dr. Singh and I saw those patients and has a better outcome than vitamin B6 and the supplementation only. Okay. So this is the first mainly and was reduced substrate. So as we mentioned, the C is the byproduct of the accumulated substrate. And when you hit the rush hour, what you're gonna do? You detour, right? And so that's the bypass. So when you have this and toxic building, and this is excellent example is urea cycle disorder or organic aciduria, they can cause high ammonia. High ammonia is toxic to brain. If we don't treat them appropriately, they can cause brain edema and even death. So develop something and remove this and toxin quicker is very important in the emergency management. So ammonia, when you are built too high, they detour. They also detour. So they can combine with 2-ketoglutarate to sensitize to glutamate. Glutamate bind another amino acid, ammonia to form to glutamine. So that's kind of a second marker of hyperammonemia when you look at the plasma amino acid. So the medication actually was sodium phenylacetate combined the glutamine. You just sucked up and this and the ammonia down. And so that's formed to phenylacetyl-glutamine and can secrete it from urine. Same thing, the other detour is ammonia formed to glycine, and glycine combined the sodium benzoate and to sensitize to the hypurate. That's also easily secreted from the urine. So that's what we called scavenger. So basically you have too high, just to make it converted to the non-toxic one and to remove that toxic. So in the emergency, and this IV form ammonia scavenger was a combination of the two medications. That's why you see and they function so quick and very effectively and quickly lower the high ammonia. So job never done, and this medication is great. However, the taste is bad, and the smell is bad, and there are a lot of sodium, and baby and usually they don't tolerate and those high sodium. So it's not great, and use that every day. So new drug and Ravicti was developed. So you can see that, and so the Ravicti is put this sodium phenylbutyrate linked to the triglyceride glycerol backbone. So they have 3 backbone. So they linked, and each one and has attached sodium phenylbutyrate. And then when they get into its oral and a medication and no taste and no color, and then it's well tolerated liquid. And so when they get to the body and your pancreas and do the first job, cut it off. So you have actually the phenylbutyrate in the body, and phenylbutyrate converted to the phenylacetate and binded to glutamine. So that's better tolerance, better compliance, and also because they slowly release. And so their half-life is longer. So in the night, you don't necessarily give. And so they have a stable ammonia control. So it's very, very well tolerated for patients. Okay, so the last and the focus for the substrate is called substrate reduction therapy, also called SRT. And then later I probably use this SRT, ERT, and the PCT and a lot, and so you know what I'm talking about. So as we mentioned, substrate is the toxic one and accumulated. So this substrate was also coming from other metabolites and as a product. So if we can block the precursor metabolic pathway and to make this and the substrate lower as a product, that's actually restore the balance in the metabolic disorder, right? So your substrate, although is precursor for the primary defect, but this one also come from other stuff, other pathway. So if you block other pathway, you make this decreased. So eventually, and your primary defect will restore the balance. So that's the focus. And an excellent example is this tyrosinemia. Tyrosinemia was caused by defect in the degradation of tyrosine, but the primary defect was at the distal, so at the bottom, and the FAH deficiency. So when you have this deficiency, you build the precursor and fumarate acetoacetate and FAA, MAA, and the precursor. And this one, and they can convert it to succinate acetone. That's the toxic one. So, however, this FAA, and compared to the previous and the earlier step of metabolism, is the product, right? So if you can block the previous step, you can make this product lower, and basically, and you lower the substrate. So the clever discovery is they found this NTBC, also called nitisinol, yeah, never end call that name, and NTBC. And so this one was an inhibitor for the previous enzyme. So that's and make this and produce less PAA and then subsequently less succinate acetone. And so it's not treated the primary defect, it's treated the previous and step. So I think this was a very like a significant discovery and for the patients. And before all those patients and end up with a liver transplant. And now they take a pill and they limit it in all this and complications. So it's still using in the clinic. So substrate and reduction therapy, actually another classic example when people talk about this therapy is in lysosomal storage disorder, especially in Gaucher disease. So Gaucher disease, you can cause liver enlargement and hematology and anemic, and the platelet was low. And so we know the precursor buildup and was the problems. And so some of the medication and like miglustate and all Sodiga, and was newly developed and was trying to same concept, block the previous step of metabolize to decrease the substrate synthetase. So advantage is, and if you compare to ERT in treatment in the lysosomal disorder, ERT has to go IV. This one was a small molecule. So you just take it by mouth. So it's easy and for patients. And also because it was a small molecule, and they can easily get to all the organs. So one of the major organs in a lot of metabolic condition is your brain. So that's across the brain barrier, and it was a huge and advance. And also they used some of the new treatment, and now is switched from the ERT to the oral medication. So it's a lot of things and still in developed. And however, we know that's great, but when you blocked the some pathway, and you created a new metabolic disorder, right? So long term, how that gonna affect the patients, we don't know. And in pregnant women, and if you give that medication, does that affect the baby? And so that's also unclear. So still has a lot of to learn. Same thing in the tyrosinemia. We know when we give an NTBC, and we make the tyrosine even higher. And so that's why patients still need some diet to reduce those levels. But for other conditions, there are so many network pathway, alternative pathway, we just don't know all of them yet. Okay. So this one, ERT was the main treatment for lysosomal storage disorder. And again, this is IV, so it's not very convenient. But it directly deliver what you're missing. So that's why, and it's the central treatment for lysosomal disorder. How they do this and is why this enzyme replacement and was mainly used in lysosomal storage disorder, not other disease. All other metabolic condition was also enzyme deficiency. Why this was so successful, not others? So this one was interesting. All this and the lysosomal enzyme has a main mannose 6-phosphatase motif. So they have those sugar added on those enzymes. So the cell has this and the M6P receptor. So this enzyme, because it's very unique, you make an enzyme, you just add those sugars, and then this can guide this enzyme and bind to the receptor and then get into the cell. But other enzymes, they don't have this and like a marker. They don't tell where to go. So that's under the enzyme is a protein, and your body has a proteinase and enzyme, and they just chopped. And so that you don't have an ability to get into the cell. That's why the uptake system was very important for developing new treatment. That's why it is very successful on lysosomal enzyme, not other enzymes. And so a lot of disadvantage, and we have to recognize is IV every 2 weeks. So patients has to take time, take to effort a lot, and also sometimes it has a reaction, and so has not under risk-free, and it's a tremendous burden and for family as well. And so cost is expensive. It's not like a trivial amount. And also because it is a protein and you have a blood-brain barrier, cannot get into the brain. So if you have a disease has a neurological presentation, this is not treatable, okay, by the ERT. And also, as we mentioned, the immunogenicity, and over time, your body can recognize it, maybe develop some neutralizing antibody, so it's not working anymore. So that's a lot of disadvantage as well. So there's another type of the enzyme treatment we called enzyme substitution treatment. So what we talked before, replacement is human enzyme. So you basically giving the enzyme go through same as a human process. But this one was coming from bacteria. And so they use the different pathway. They are not convert phenylalanine to tyrosine. So they use the bacteria, use this enzyme to convert phenylalanine to ammonia and other metabolites. So you're not to restore the metabolic defect. That's why, and some patients still need to watch their tyrosine level when they use their treatment. Again, this is coming from bacteria, not human protein. So body and will recognize as a foreign body. So they're gonna trigger the immune response. So the significant and disadvantage is you do facing the allergic reaction, especially anaphylaxis. This can happen. And we actually just published, got accepted when we have a patient develop a severe anaphylaxis, and when we're using Palynziq, and she has suddenly, and 3 minutes after the injection, and develop a rash all over the place, and swelling of the eyes, mouth, and difficult breathing, and also vomiting, and nausea, vomiting, and they have to carry EpiPen all the time. So luckily, and she has that in the purse, and got injected herself and went to the ER. And so in that case, it's very difficult to reinitiate and without supervising, right? So it can be life-threatening. So we worked with immunology and in the very controlled setting at the immunology clinic, and they give this desensitization. With the 6 hours and the desensitization protocol to overcome this. And so the second day she used at home by herself. So that's a significant contribution and for future use, because it's working and we don't want to take away from patients. So the other one, and first we talked about you missing enzyme, we give you enzyme. So this one is you're not missing totally, and you still have some residue enzyme activity. So we give you the helper, and this was called pharmacologic and chaperone treatment. So this chaperone is also a very small molecule drugs. They're not protein, they're just a small molecule drugs. So this molecule can bind to the enzyme. And a lot of them, a defect enzyme, they're misfolded. So when this binded to the enzyme, they can correct this misfolding and actually boost the enzyme activity. So a lot of advantage, as we mentioned, compared to traditional protein or enzyme treatment, and that was oral. Same as substrate treatment, it's oral medication, very small molecule drugs, and broad and bioavailability. They can go to everywhere in your brain, and including, okay? And so because it's not the protein, so they have a limited, no immunogenic side effect. And so they also, because it's not a foreign body, it's not made enzyme. They use your own enzyme. So it's kind of a restore the physiological process in the body. And so also, and has a very, some of the medication they tried in even other disease. And so they have a very good and safety profile. So that's easily to screen this type of treatment. Disadvantage is it's not all patients can use this treatment. For example, if you don't have enzyme at all, you have a null mutation and a stop codon mutation, this is not the appropriate treatment strategy. So Galafold is a newly developed chaperone treatment for Fabry disease. So patients and mutation has to be tested, and in the in vitro system, they use the cell and created the same mutation as the patients, and then test the cell if it is working. If it's working, and you can try this in the treatment. If not working, basically, and you are not a candidate for this treatment. And the PKU and the Kuan actually is also, although we call cofactor, and the cofactor was also kind of a chaperone. You give this and a large amount of physiological or pharmacological cofactor, you basically help the enzyme stabilize the enzyme and increase the enzyme activity. We all has a good experience for Kuvan in treating PKU patients. Okay, so we talked to the replace enzyme, we talked about a help enzyme, and how about we give something and you produce enzyme by yourself. And so this is coming from the cell therapy or organ transplantation. So hematopoietic stem cell transplant has been used for many diseases in the past. And they basically give you this stem cell, and then your stem cell can still produce the normal enzyme, but also this enzyme can sustain because you have the cell in your body and they continue produce the enzyme. And however, successful is very variable, and it's depending on when you give the patients. If the patients already suffer from the irreversible deficit or brain damage, this is not gonna work, right? So that's why we emphasize the early detection, early diagnosis for newborn screening, and give this an opportunity to treat these patients in those narrow treatment window before they're symptomatic. And also, this one, because it's a cell does not go through the blood-brain barrier. All is a focus on how you get to the brain. And so the enzyme produced by the cell may be not adequate. So we are still facing difficulty how we treat a neurological presentation. Of course, and then you have to do transplant. You give somebody else's cell, your body gonna recognize foreign body, enemy. So they're gonna have immune response. So all these patients has to use immune suppression treatment. And also transplant is a surgery. And so those complications and can change the outcome. And because it was other people's cell, and so you probably will, is that engraft, and so there also has the risk for graft versus host disease. So that's everything. This can happen in every transplant situation. And patients has to be used lifelong immune suppression. Okay. So liver transplant. We know and the liver is a major metabolic center. So that's not surprising why people are thinking about liver transplant. Liver transplant, and it's a great treatment strategy for some condition. They purely metabolize in the liver. What disease that is? Urea cycle disorder. So all the enzyme only in the liver expressed. And so if you fix the liver, you fix the disease. So that's very successful, and in the some condition like urea cycle disorder, OTC, and we have a couple of patients just had a liver transplant done recently. And some other metabolism, although happened in the liver, but has a significant extrahepatic and enzyme activity. For example, PA and MMA. And you have enzyme in your liver, but you also have those enzymes working in your brain, in your kidney, and your heart. And if you only fix in the liver, you're good, and you limited and the hyperammonemia episodes, but you didn't limit it metabolic stroke, and your kidney and the failure, and your heart and cardiomyopathy, those kind of complications. So liver transplant was only used as an alternative and option and for patients, not cure them. MSUD is a very important and very, very interesting and entity. And so MSUD, 60% enzyme is in the muscle, and 40, 50, and it was in the liver. So when you give a patient a liver transplant, that restore about 13% of enzyme activity. So that's actually enough for your body and metabolize what you generally eat. So you can liberate a diet after the liver transplant, because 10% enzyme is considered adequate for the disease. However, after the transplant, if you encountered significant stress, your body and the catabolic and so much protein was released, that still could cause metabolic defect. So that's why, and it's not treat everything. And interestingly, the patients, because you and me and we all have 60% in our muscle. If we need something and for the liver transplant, and for example, patients has other disease cause the liver failure, and for those patients, because the enzyme, MSUD enzyme, still have a 60% working in the muscle. So if you got an MSUD patient's liver, and then give to those patients with a liver failure, but normal, but no MSUD disease, and that's still functional normal, because the 60% for muscle take care all you eat. So that's the people have a MSUD, got liver from other patients, and but take off MSUD patient's liver, can give to another patients who have a liver failure. We call this process domino transplant. So in the setting of lack of a donor and the lack of a supply of liver, I think this was very useful approach and to help more people. We have one?
Yeah,
Did
we have
a
one patient
domino,
here, yeah,
mhm.
from memory.
So both patients are doing well. So the other thing is, it's great, and you can treat and the underlying problems, but transplant, as again, is a procedure. So peri or post surgery care and multidisciplinary care is crucial for success. If they're past the surgery period, like the procedure, and that's a big success. But down the road, and we still need immune suppression treatment. Okay, so this got my most exciting field, and it's a gene therapy. So gene therapy, and there are many types of gene therapy, and I want to clarify. And first, and we're talking about gene replacement. It's also called gene transfer therapy. There are two types. One type is called ex vivo, which you take the patient's and the cell, the stem cell, and then you correct it on the outside, on the dishes, and then you transfuse this cell back to the patients. So there certainly has the advantage because it's your own cell, you don't fight, right? And so that's you don't need a HLA match, you don't need a searching donor, and so you don't have the risk of grafting versus host disease. So that's great, and you don't need immune suppression. It's great, but the disadvantage about this is supply and limited in graft. So that's a lot of times it was not success, but has a success story. And for the X-linked adrenal leukodystrophy, and they just published data a couple of years ago, and 17 cases received this, and they certainly postponed any neurological crisis. So the other type, and it was in vivo. So in vivo is you give give this gene using a vector. So this vector and either virus, and commonly used was adeno-associated virus, because the efficacy and safety and has been tested in multiple preclinical trials. And some of them was delivered by other non-virus vector, and called lipid nanoparticle. It's a very small, and you put in your gene and inside that you can transfuse. And so you can just use the IV and give this virus or this vector, and then they deliver to the patients. So recently, I know we gave a talk for hemophilia A gene therapy using the AAV5 as a vector, and pretty successful, and after 3 years of follow-up. So two types, ex vivo and in vivo. So currently we are conducting phase 1, phase 2 gene therapy, gene transfer therapy, and for PKU. So we are one of the site in US. So you got this and PKU gene and a PAH gene. You put in the vector, the virus. This virus there are actually two trials currently. One is from Homology, and they use a different virus, but has been tested in other animal study and worked pretty well. And so they put this in the human PKU gene into the virus, and then give the IV and one time only in 1 hour infusion. And then this and the virus, because has a liver specific promoter. So when they get to the liver and they expressed, and when they get to the other place, they don't express. And so they only expressed in the liver. So this was not integrated to your genome. So there is no off target and effect. And so they just stay as their own, as the episome. So they're separate with your genome, like a nucleotide. And so those one continue make this PKU enzyme. And you also have your own defected enzyme, but this one and continue separately make the normal enzyme that's treat the disease. So hopefully we have a patients enroll and we can see the better outcome. And so currently the first homology trial is enrolled 2 cohort, and so they're still in the dosing escalation phase. The first cohort actually did not show effect because they're low dose. And the second cohort, and by the data release, publicly released, there one patient has a 50%, almost a 50% down. So that sent us pretty well. They are still escalation to the higher dose, so we don't have those data yet. So this is the immediately risk for this is when you give a patient a large amount of a virus, what's your body gonna do? You're gonna fight. You have inflammation, and you have to use immune suppression. So those are one immediately like a side effect. So those patients, we have to give steroids, make sure body settle down. So second, like this and the homology trial, and the first cohort, it doesn't work because we don't know in human how high the dose is appropriate. Also, even for specific patients, is this dosing are perfectly for you, just working, not too low, not too high. So that's definitely how effectively deliver. It's a question. So every patient enroll this trial, we have to review all this risk and benefit. You heard about, oh, one time, 1 hour, I'm gonna done, and it's not that easy. And your patients has to understand the risk. And after they give this, it's only one time. So you don't have the second chance to use this treatment anymore because then your body gonna produce antibody for this virus. So we can't give you another time. And so if you use another one, has to be other virus or other vector. So that's the immediate risk of ineffective delivery. So we don't know yet. Okay, and BioMarin has the gene therapy in developed, and so I think they are launching this year, and they use the same factor as a hemophilia A, so which they already tried in human. So it's good, always good. It has some other options, and if patients has a vector antibody for one virus, maybe not for another. So I think provide patients more options. Yeah, we talked about this immune response in the active liver, but this one because they don't go into your genome, so they don't have an off-target effect, and usually they don't cause any cancer risk. So the other type of gene therapy is called gene editing. So editing means you changed the wrong one, right? And so many and was you have to correct the patient's one. So especially and after the CRISPR-Cas9 system, editing system developed, and this one was being used for multiple like a situation and animal studies and preclinical data. And actually now there are 2 conditions, and a very well-known condition, PKU and parasinemia, already have animal study and use this editing approach and correct the mouse and the gene, and then patients and correct the disease. So hopefully, and this can well applied to human in the future. So this one has an advantage compared to gene transfer. Gene transfer, because you didn't integrate it to patient's genome, right? And so over time, those can lose. So that's only applied to adult. And so the adult cell do not separate. When your cell still divided, and you only has those amount and episome. So when you divide it, some of the cell will be no episome. And so for the dividing cell, it's not a good option and for gene transfer. But gene editing, because you added patient's genome, so even they are dividing, so your genome is still there. And so that's why, and this could apply to children. Okay. Another one, another type of gene therapy is called mRNA therapy. So we all know DNA and transcript to RNA, RNA translated to the protein. Eventually, your goal is you want this protein, right? And so you can deliver DNA. You also can deliver the RNA, which was essential of this process. So And when you give an appropriate amount of RNA and you put in the some vector and then you transfuse and get into your liver, you have RNA, you guide your protein synthesis machine and make the protein. So basically one step close to make enzyme. But this one and has some advantage, some disadvantage. Advantage is and they don't integrate to your genome. And so that's no other off-target effect. And you can repeatedly use. It's not one-time only. You can adjust the dosing. And if you don't have a sufficient enzyme, okay, I'll give you another one. So it's flexible. So that also because they're short, they cut and they're already processed. The DNA, like the RNA is shorter and it's easy to pack in. Some people said maybe we should develop a ER mRNA and for all the metabolic condition. When we don't know these patients what they have, we just give this pill and this and the mRNA combined and many disease and anyway I can treat any disease. So it's just a shorter and a quicker and rapid develop candidate to use this method. So it also has clinical trial right now. So we are also a site for this phase 1, phase 2 trial for isolated methylmalonic aciduria. So the enzyme was mutase, MMA mutase deficiency. So the mutase mRNA was packed into this lipid nanoparticle. And then you just give IV infusion and this one get into your liver and the liver cell and then produce the enzyme. This enzyme going to the mitochondria and bind it to the cofactor and then they process as a normal enzyme. So this one was still in phase 1, phase 2 trial. We hope that we have patients enrolled. Probably has one candidate so far. Okay, so last one. I don't know anyone heard about this Mila miracle story. So Mila is 6 years old and she has slowly developed vision loss, ataxia, seizure, and developmental regression. So they finally, and the genome sequencing, and they identified she has a very unique mutation, which was located, and this was the her mutation, which was located in the intron 6, so this one. And so they have a small duplication and added in this intron 6, actually created a cryptic splicing site. So when they splice into the mRNA, and then you just take the intron off, because they created this cryptic and splicing site. And so they added this additional 16 base pair, and it's actually eventually caused the premature translation termination, and that's caused the problems. So the mother found a foundation and raised a lot of money, and they used the Mila's cell and in the dishes to test if we can block this splicing, can that restore the process. So they did all this in the bench work using the patient's cell and to test which one can block this splicing. And so finally, and they use antisense nucleotide. Just the principle, just like the nusinersen for SMA treatment. And that was also one type of the antisense nucleotide. So after they tested it working, they found they used many type of the antisense nucleotide and find one work very well. And so they made and manufactured and then give Mila, and after give to her, and her seizure was significantly decreased. And so developmental was like a progress was kind of a slowdown. So I think this case was illustrated and the individualized genome medicine. So I think this also very likely will be the future of the precision treatment, like medicine. However, this type of work, and it's very difficult and to get the funding for one single patient, but it's a proof the concept and it work. And so bottom line is our work never done. And so a lot of things and need us and work together, and we definitely can help more. So at the end, this was actually from that review article, and it's summarized all the pros and cons of various and treatment strategy. And if you're interested, you can read about it later. I think my last slides and summarized slides is simple, and so I hope and we also covered and some of the new development. The principle is there, so it's how you think about and adding clever discovery and with the same principle. I think that's it. Thank you,
Thank you, Dr. Lee. I think it was an excellent talk to bring us up to speed in all the therapies. Unfortunately, we have just made it to the time, but I will open for a quick question from the audience here, and then if somebody wants to post one question from people who are signed in. Is there anyone has a question from our audience here?
There's always a question. Yeah, to resolve it.
I know you said that for the stem cells, there's sometimes an issue with like supply for the ex vivo therapies. I know too that like people like to harvest the stem cells when their babies are born. Is that an option or like something that we could recommend